Great. Welcome, everybody. We'll get started in a few minutes. The main session hasn't finished yet, so we're running a little bit late. We'll get started in about 3 minutes or so. All right, okay, we're gonna get started. Apologies for the delay. We're trying to keep up with the other rooms that are finishing late. So welcome to this Women in Surgery session. We're gonna be talking about a number of different topics to try to figure out what is it being a woman in surgery and what has it got to do with a few different things in perioperative management and the practice of surgery. So I'm Juliette. I'm a surgical oncologist and HPB surgeon at the University of Toronto in Canada. I'll let my co-moderator.
And my name is Jen Pasco, and I am a hepatobiliary surgeon at Providence Sacred Heart in Spokane, Washington.
All right, so I'm going to start. We're going to have a few talks, and after each talk, we're going to go to our panel to have some discussions about the topics that we just heard about. We also encourage a lot of interaction with the audience, so please, we don't have mics here, but get up, ask questions, provide input. This is really what this session is meant for. We have a panel of a few people that are here to sort of represent different stages in career, different practice settings, so we can get their input on the topics we're discussing. So maybe I'll present them first, and then we'll start with our speakers. So in our panel, we have Dr. Elena Facundo, who's a gastrointestinal and HPB surgeon at the Instituto Nacional de Cancerología in Bogota, Colombia. We have Dr. Chris Sunenday, who is an HPB and transplant surgeon and associate professor of surgery at the University of Michigan. Dr. Erin Menard, who's a transplant surgeon and the associate director of the general surgery residency program at OHSU. And finally, Dr. Purvi Parikh, who's a HPB surgeon and surgical oncologist at Rochester Regional Health. So now we'll start with our first speaker.
Yeah, I have the honor of introducing our first speaker today, who's Catherine Morgan. Dr. Morgan is a professor of surgery and chief of the Division of GI and Laparoscopic Surgery at Medical University of South Carolina. She's joining us today, and she's going to be talking about what it's got to do with brilliance. What's the brilliance bias in surgery?
There we go. Great. Thank you so much to the moderators and for and to the program committee for having me here today. This is my favorite session of the meeting, so I'm very honored to be here speaking. So I'm going to be speaking about brilliance bias, which is an unconscious bias, but I wanted to just keep the perspective that gender discrimination is a spectrum. And while they seem like very different entities, there's really a lot of overlap and gray amongst the different kinds of gender discrimination. And I think we all feel like we're in a different world and have come a long way since the Me Too movement and since Harvey Weinstein and sexual harassment. But just last month, another post-Absite survey came out with, again, some kind of shocking numbers showing that 31% of surgical residents reported sexual harassment in their job. And so it's still very much a problem for us to work on. So unconscious bias or implicit bias are learned stereotypes that are automatic, unintentional, and deeply ingrained, and they're able to influence behavior. What's interesting about them is that they're culturally generated and driven, and they're pervasive. And they're also pretty prevalently unrecognized. And so between the lack of insight and their deep cultural basis, they're really hard to affect or change. We're also trained to have bias, to stereotype as surgeons. And so I think all of us as HPB surgeons, you walk into a room and in the first few moments of meeting a patient and their family, you have to stereotype them enough to be able to figure out how to deliver difficult information to them and to sort of how to frame your conversation. And so again, not only do we have it culturally entrenched, but we're also training ourselves to stereotype and to bring bias. How many people in the room, let me see a show of hands, have done the Harvard Implicit Association test? Yeah, so if you haven't done it, it's kind of a fun online survey. And I think obviously there's good data behind it, but I would just call into question some of the funny anecdotes I've had where one of my colleagues was reported for gender bias, and he said to me, I don't understand. I took the Harvard Implicit Association test and got a really good score. Surely this report is bogus. And then I had a medical student tell me he'd taken the test so many times in so many different classes, he was starting to get good at it. And I don't think he meant that he was starting to realize his own implicit biases. And then, the other thing I would warn about is the bias blind spot. We all have biases. Just as Dr. Shapiro said, we're all judgy. We all have them. And so if you think that you aren't biased or that you are noticing it more in your colleagues and thinking that you're above them, I think it's important to realize that you may have some work to do. We all do. So these are some examples of common unconscious biases that we encounter in work that negatively affect women. Affinity bias is hiring, promoting, collaborating, mentoring like people preferentially. So this is where you go to hire someone and there's a lot of subjectivity that goes into that, and you want to hire them because you think they'd fit in. And obviously that's not the best way to build a team. Appropriation, mansplaining, and manterruption are unfortunately very common behaviors that happen in any meeting in the current surgical academia, for sure. Appropriation is where a woman puts forth an idea and it's met with sort of lukewarm regard, and then a man seems to paraphrase and promote the same idea, and all of a sudden it's a genius idea. Confirmation bias is the idea of taking your already preconceived notions and using the information at hand to just support or confirm your biases. And then performance support and reward bias is giving differential support, resource, or pay to people. And then finally, brilliance bias. So brilliance bias is the tendency to think of brilliance or genius as a male characteristic. It's also a negative stereotype of female intellectual abilities. This is most relevant in fields where natural talent or brilliance is felt to be essential for success. So STEM careers, for example, are really influenced by brilliance bias. So we're, as medical people, very vulnerable to this. And then also I think it's interesting that musical composition and theory is also heavily thought to be, obviously, need natural talent for success. So there's also brilliance bias here. So, as I said, unconscious biases are culturally driven, culturally generated and driven. And it's interesting. I'm going to go through some different data showing brilliance bias or evidence for brilliance bias. But gender stereotypes about intellectual ability emerge really early and influence children's interests. So this group that I'm going to show a few different studies that they did, they took children that as they were entering into kindergarten, so age 5 to 7, and they were told a story about someone who was very, very smart. And then they're asked to pick from some images that they saw and that were male and female and tell who they thought the protagonist looked like. And at 5, at the beginning of kindergarten, children associated brilliance with their own gender. So little girls picked the women, or little girls picked the female protagonist, and little boys picked the male. But then as they got a little bit older and not that much older, so as they were leaving kindergarten, age 6 and 7, little girls started to pick the male pictures as the very, very smart protagonist. And then the same group did another study where they introduced some children, again, young children, to 2 novel games. The first one, they introduced the game that it was a game that was for children that were really, really smart. And the other one was described as being for children that try really hard. The 5-year-olds had no significant gender differences. But again, by the age of 6 to 7, girls were less interested than boys in the games in the game for children that were very, very smart, but equally interested in the game for children that try very hard. I think this one's interesting to me because a lot of the parenting stuff that I read a decade or so ago really told you that you should always tell your kid or congratulate your kids not on their performance or on their qualities, but on how hard they tried. And so maybe we have to rethink some of the things that we tell children. And then here's another sort of confirmatory test that shows that culture really introduces brilliance bias early. There's this draw a scientist test that David Chambers developed in the 1980s. And so he gave this test for decades and then did a meta-analysis looking at children at the beginning of kindergarten and then later in as they went through school. And they found that, again, at the beginning of kindergarten, children, when asked to draw a scientist, drew equal numbers of female and male scientists. But as they got older, there were more and more male scientists. And then it's not just children. This brilliance bias does persist into adulthood. There are some implicit association tests studies that have shown that evaluating trait gender associations in both adults and children strongly and consistently link brilliance as a male trait more than any other trait. So they looked at other sort of personality or quality traits such as funny, creative, and other qualities of people, and the brilliance always paired very strongly with males, whereas funny and creative are more with female. And the only discrepancy from that was the trait strong did associate with males. And then even more pertinently, in healthcare workers and in surgeons specifically, implicit association tests showed that respondents associated men with career and surgery and women with family and family medicine. So clearly these biases are last and are durable through adulthood. I don't know that I need to have this slide, but obviously this is not a biologically based phenomenon. This is a culturally based phenomenon. Girls are actually really good at school. They make up more than half of children in the gifted and talented school programs in the US. Girls get better grades than boys in kindergarten all the way through 12th grade. And women have higher rates of college, master's programs, and doctoral school graduation than men. And so they're actually pretty good at school, and that would imply intelligence, one would think. And this is part of the problem is that, the role models, the historical role models that children are shown are white male scientists. And that's the history that they're given. And that's what they're shown that a successful, genius, brilliant scientist is. And you say, well, that's history and that's the way it was written. And you can argue that it was written in a biased perspective. But even modern day examples of leadership are men, and examples of genius are men. So these are all modern day. This actually came from, I Googled who are the top 50 geniuses. And of the top, there were several lists of top 50 geniuses. And in every list, there was not more than 3 women in the 50-person list. Another effect is the Matilda effect. And so the Matthew effect was first described in 1968 by Robert Merton. He was referencing apparently a verse of the Bible from the book of Matthew about how people who have will have more. And the Matthew effect was the idea that people who have already been successful are more likely to continue to receive credit. And he was referencing a physicist who had done great work in Brownian motion, but was ignored because Albert Einstein had been working at the same time and so was receiving a lot of the credit. And then the Matilda effect was coined, that term was coined by Margaret Rossiter in 1993. She named it after Matilda Gage, who articulated the phenomenon. She was a suffragist who articulated this phenomenon back in the late 1800s. But the Matilda effect is the systematic under-recognition of the work of female scientists. And so do we have the Matilda effect in academic medicine? Unfortunately, we do. Men are more often journal reviewers or editors, as we know. Female authored papers are more often accepted or rated higher with a double-blind peer review process. I'm sorry, they do better with a double-blind peer review process than they do if their gender is revealed. Women are significantly underrepresented on single author papers or as first or last authors on papers. Men are 1.7 times more likely to cite themselves. And female scientists receive grants and scientific awards less often compared to male colleagues with equal requirements. So clearly there's some underappreciation of women's accomplishments in scientific medicine. And then we've seen these numbers, but just to remind us that there's a lot of gender disparity in surgery on all levels. Despite the fact that there were more than half of first-year medical students were women in 2017, and half of surgeons today, or 48% of surgeons today, are women. Only 26% of surgical academic faculty are women, and that's the percentage decreases as you increase in academic rank, and only 12% of full professors of surgery are women. 27 women, this is by my count, so hopefully I'm right, are department chairs in the US currently, which is only 7% of department chairs in this country. And women surgeons earn 8% less than men when controlling for specialty, academic rank, and productivity. And I think we all agree that women are essential to best medicine and surgery. And so this brilliance bias is one of the barriers to the professional advancement of women in surgery. It negatively impacts advancement opportunities. So they're offered less often offered appropriate opportunities, but it also undermines women's own career goals, and it tends to lend to imposter syndrome, where women feel like they don't deserve to advance. This book I actually just came out last week. I was reading, it caught my attention because I was preparing for this talk and read about it in the Wall Street Journal, and just I'm on the last chapter, but it's fantastic, and so I highly recommend it. I'm not a big nonfiction person, but this is really well written. It's by a reporter from the Boston Globe, but it tells the story of Nancy Hopkins, who was a molecular biologist at MIT in the 70s, 80s, 90s. And it kind of tells her story along with many of her colleagues, women colleagues at the time. This is a quote from the book. It says, "Women who succeeded in science were called exceptional, as if it were unusual for them to be so bright. Many had pushed past discrimination for years by excusing individual situations or incidents, explained not by bias, but by circumstance. Only when they came together did the MIT women see the pattern. That recognition alone made them exceptional too." So it's very nice anecdotal, and it's written in a very even, balanced manner, and it really nicely presents their struggle with, they felt like at 30, if they didn't accomplish everything they could by 30, their career was done because they needed to have children at 30. And so it's an interesting read. So Nancy Hopkins was the chair of the Committee on Women, was appointed a chair of Committee on Women at MIT Her committee put together a report on the state of gender bias in 1999. So not in 1970, but more recently. And that report was then promoted, and it was backed by the president of MIT, Charles Vest, at the time. He said, "I've always believed that contemporary gender discrimination within universities is part reality and part perception. True, but I now understand that reality is by far the greater part of the balance." And so MIT really, after this very important report and this very important endorsement, became a leader for gender equality and gender advancement in science. So brilliance bias, it exists. How do we change it? So bias training is an $8 billion industry, but there's no evidence to show that it really is terribly effective. Multiple studies show how it does not infiltrate unconscious bias or reduce discrimination. And we all know that it's the person that actually shows explicit bias in the room that complains about the time wasted they just had by the bias lecture. And at worst, it amplifies the issue. Depending on the setting, the audience may feel accused or become defensive. We've all heard the excuse of locker room talk and people being too sensitive and saying, "I'm not Harvey Weinstein." And as Pam in the office says, usually the day we talk about sexual harassment is the day that everyone harasses me. So if it's not bias training, how else do we affect change? We talked about this earlier, presenting a more inclusive history, her story, making sure that we include the important women and their accomplishments and stories as we can. And then even easier is present day female role modeling. So not focusing just on the men who have accomplished things, but on the women that are doing important things as well. And then changing the image. So, some of our own HPB surgeons with the hashtag look like a surgeon and the hashtag #medbikini social media campaigns are important to change the image of women. And then intentional mentorship. So really seeking out women to mentor is both as men and as women. Another way we talked about how this is culturally ingrained early. So pathway programs or pipeline programs are a fantastic way to really make it a difference. If we could get to the children in kindergarten, that would be the best. And we're not quite there yet. We at MUSC have a pathway program that we are changing and evolving and developing, but it targets underrepresented medicine participants. So we've targeted a particular high school that's under-resourced in Charleston, and finding recruits. And then, these people are under-resourced, and so that we offer them a summer job so they get paid. Often they've been scribes or done other tasks that don't require much training. And then during that summer, they get a shadowing experience. They get some, clinical small group educational series, but they also get professional skills training. So they learn how to do an interview, how to write a resume, maybe how to do a personal statement, and how to make a budget. So it's a pretty good program that we're working on. Mostly, we've done it with college students, and now we're adapting it for high school students, although the funding is more challenging. Other things we can do, practice upstanding. We heard from Michelle Mello in the New England Journal a few years ago about the imperative ethical obligation to intervene, witness gender bias. So bystander training. The She Leads Healthcare hashtag Be Ethical campaign similarly promotes change within the system and bystander training. And then having zero tolerance policies whenever leadership is able to make some rules within, for example, the surgery department. These are positive implementation processes. So diversify the team, we talked about that, but more importantly, diversify the leadership. And the question is, how do we do that? I think the word affirmative or the term affirmative action gets a lot of sort of negative implication. So I like to say have a more democratic recruitment process, which means, make sure that more women are brought to the plate. So if you have 3 candidates and they're all men for a job, then you haven't done a great recruitment process. And it really involves, active recruitment. So going to where represented medicine people are trained or are educated would be a great place to start. And then asking all kinds of colleagues for recommendations for jobs. And so that's it. A little wellness humor here.
I guess my first question for the panel is, I feel very lucky that I trained in a place where I had both male and female mentors. And I guess my question is how does the leadership play a large role in the environment that you train in and that, we all work in? And maybe I'll direct this question to Dr. Sanade first, because I know you're a great mentor for several women, but, I think males play a very important role in breaking the unconscious bias.
Thanks. I don't know that I have a direct answer to that. And honestly, most of what I've learned in this area has been by screwing it up before. I think to speak to some of the things that Dr. Morgan mentioned at the end of her talk, I think from a systems level, the only way to change this is very intentional, transparent work. I agree with Katie that you can, unconscious bias train till the end of time, and it backfires, I think, more often than I've seen be real successful. As an example, I'll give you a positive and negative example. As a positive example, our department about 6 or 7 years ago completely changed our recruitment approach in exactly some of the ways that Katie described. We changed the way we advertise jobs. We changed the way we handle the CV, submission process, and certainly the way that candidates are interviewed and such. And it has been remarkable in terms of attracting people to our faculty who have been very honest with us. They never would have even considered, coming to Michigan if we're not for that change. I think the negative thing is what we've learned is that that's just the first step, right? And we have started to see some faculty and residents who have joined our department who are excelling in kind of their own domain, but don't feel, totally supported because the level of individuals that they look up to don't look like them, because that's not, how the department was constructed historically. And I think acknowledging that and being very kind of intentional and transparent about that is really important. But it's a journey that I think all of us have to be actively engaged in to make any progress.
Yeah, please feel free to ask questions for the panel. Dr. Orloff, yes. We don't have a microphone, so speak up. Oh, here's a microphone. Oh my God.
Thank you so much. Thank you for your wonderful talk. It was, as I said, phenomenal. You alluded to the fact that in terms of educating underrepresented minorities, high school students, college students, and I really feel like we have to start with Head Start programs, start in kindergarten, start very early, because what I feel we are doing is we're throwing people into, say, medical school and residency programs, those that are underrepresented minorities and such, and it sets them up for failure because they haven't had the background from day one to really be educated in the way others that are more privileged are educated. And so I think we have to emphasize the, like I said, Head Start program, starting in kindergarten, starting really early, so that those people that are thrown into college, medical school residency for that, the DEI checkbox for the institution, they're actually set up for failure. And I'm just curious about your thoughts or anybody else's thoughts about that.
I completely agree. Ideally, in Charleston, at least, we struggle with getting, under-resourced children basic education in kindergarten. So I think that's a huge, I'm not saying I don't want to be negative, but that's a huge process or a huge goal. But I agree. I mean, if we can, the earlier we can start, absolutely, the better. I think we've seen more successes with some of our private schools that are able to do, to have more, scholarship, or to have more, to diversify the private schools. We've had some success with sort of getting exposure there where the resource is. That's not the answer, but I agree. I mean, the earlier the better, for sure. You don't have young women have to want or to believe they can do these things, can be a doctor, to go down that path. And if you start at 5 hearing that that's not what you're meant to do, you're not going to do it,
I just wanted to say, so I don't know if I could hear me, but I just wanted to say something a little bit to what Dr. Orlov said. I think it's incredibly important that we start with Head Start. I think it's incredibly important that we eradicate poverty and systemic racism and everything else. When we're looking at a medical student or a trainee that's in front of us, we can't excuse our failure to support them by saying, well, they really should have had a Head Start when they're 5 years old. When there's somebody in front of us, we need to help do our part. Unless we are volunteering in those Head Starts, or we're voting for people that are paying for people to be able to eat, I think it's very important for us to also ask what we can do, because we can't do everything. And so sometimes there's a failure of us. We just feel so overwhelmed by the problem, because we all believe in equity, but I think the way I try to deal with these feel too large problems are, I ask, what can I do? And some of that is vote, but some of that is actually help the individual medical student, even if they didn't have necessarily the privileges to have their SAT prep and their MCAT prep and their whatever preps people do nowadays. So I just wanted to pull that up, because I'm just, for anybody who feels overwhelmed by fixing all the isms in this, in that exist.
Agree.
And so thinking about that, how do you suggest we address this? Because there's sort of deconstructing or preventing the bias, but then there's also deconstructing the repercussions that bias has on people who have integrated it for so long. Any tips or tricks from your institution, Dr. Sang? Unteach what women might have learned by the time they get to be the resident in front of you?
That's part of Head
I need a 5-year-old to help me do the mic. I'm sorry. I'm just trying to understand the question. This is about suggestions and how we at an institution try to help break.
Yeah, I guess when we have that resident in front of us who has like integrated this brilliance bias that they fought against for a long time, like how do we help them get over that? Like in a practical manner, that's one thing I think a lot of people
Yeah.
struggle with.
I mean, I really think
Yeah.
every day not every day, but many days there's an opportunity for upstanding, for sure. And I think that's probably, and depending on your relationship with your colleagues and the way it's delivered, that can make some change. Or
I think the data is important. I think that's why these papers that Dr. Morgan, and I'm sure all of you will cite, are important, because you need to ask the questions. When I was in college, I took a class called Human Behavioral Biology by a brilliant person named Robert Sapolsky. And I went to college like in the 1800s or something, but in that time, it's actually 1987 or 8. I took this class. He had a whole class of men and women at Stanford, big auditorium of like, I don't know how many people, hundreds of people. And he said, how many of you think that boys do better than girls on the math portion of the SAT? So everybody raises their hand pretty much. And he said, how many of you know the difference? Nobody raises their hand. Not one blessed person raises their hand. And so he shows the curve, right? And this is actually no longer true, but at the time it was true. We all knew it. And so the curves were superimposable. I mean, I'm nearsighted, and so from here I wouldn't be able to see it. So they were superimposable. It was statistically different, because this is like hundreds of millions of kids taking the SAT. But what Dr. Sapolsky said was, so if a boy walks next to you on the street and you pick the boy, got the higher math SAT score because he's a boy, you'll be right 52% of the time, but you're going to be wrong 48% of the time. And that was one of the most useful lectures I've ever had. So when you look at somebody and they're an X or a Y, you think because of the way we all taught to to think, we just need to be able to question our assumptions. So what I tell people is these stereotypes are wrong far more than they are right. And I always say you're comparing your own insides, your own doubts, because you're not a monster, so you have doubts and you worry, to other people's outsides. And some people, almost everyone has doubts, and if they don't, they're a monster. And so you just, and so I just try to deal with people one-on-one and realize that we believe in you. What can we do to help you? And then it's our job to help them as opposed to their job to figure it out on their own.
Hello, my name is Sahar. I'm a medical student, and I just wanted to answer your question from my perspective as a student. So far in my training, I have unfortunately yet to be able to work with an attending female surgeon. Throughout my entire very short-lived surgical clinical rotation, all my attendings have been male. There have been residents that are female, and so that's great to see. But I think to sort of address what you were saying is having more female mentorship. I'm sure there are female attending surgeons out there, but they're not sort of mentoring right now, at least in the geographical region that I'm in. So having that sort of accessible for female medical students who want to go into any specialty where there may be less women in the field, I think could help sort of address some of the biases, sort of help us go through the process as well.
Yeah, I think Jenny and I are about the same age. I think, back there weren't female role models a while back. And so I think probably many of us in the older people in the room had phenomenal male role models like Dr. Sanande, today, but he was not my mom. But but I'm just saying that, like I had the best mentor in the world, and it was a man. So those are great role models too. But I hear you. I mean, it's challenging to find, and it is an easier role model to fall into for sure.
So role models and then getting the data in front of people to understand that it can be the same so that we can see what it is. So maybe that's a good segue to our next talk.
Yeah, so I have the opportunity of introducing our next speaker. This is Dr. Natalie Coburn. She is the professor of surgery at the University of Toronto and practices at Sunnybrook Medical Center, where she is a surgical oncologist. She has a master's of public health in quantitative methods from Harvard University. Today, she'll be speaking on what does the women in surgery, what's it got to do with patient outcomes?
Great. Thank you. Thank you for the opportunity to speak today. It's fantastic to see so many people in the room, especially 5:30 on a Friday, especially when we're competing with major complications, because I think that's why we all came here, is to learn about those things. So I think this is also very important. So I'm a population-based outcome researcher. I have an amazing team, and I'm going to talk a lot about the work that my amazing team has conducted. I'm not an education researcher. I think this is critical when we're looking at how we got to this point. I don't study gender bias. I don't study psychology. So that's my background for this. I'm also a mother. I have two daughters, 17 and 11, and I have a son who's 14. I'm accused nearly weekly by the 17-year-old to make sexist decisions, assigning tasks, and treating them differently in terms of expectations for homework. So I'm reminded every week how I fail at this. And this is a very hard conversation. There are a lot of things, there are a lot of minefields for all of us to step in when we start having these conversations, but we have to have these conversations to improve. So the learning objectives are to talk about the relationship of sex and gender and outcomes, and to discuss some of the potential factors that drive this relationship. Yep. We have to have this grounded in definitions. So we can only examine and publish on things that we can measure. We can measure sex of the patient. We can measure sex of the provider. Those are biologic constructs. We cannot measure gender, and we cannot measure societal gender roles. We can't really measure very well socioeconomic background of physicians. In some situations we can, because we can know where people trained. We can't measure race very well in our databases. We certainly can't measure ethnicity, disability, and hierarchical issues. So there's a lot of issues that we have when we make these publications. And I'm not going to talk today about whether this is nature versus nurture, but I think my bias is that there's a heavy dose of nurture in all of this. So we know that within all careers, all areas of society, there's sex and gender disparities, and medicine is no different. We know that there are differences in the way we write letters of recommendation, in the way we speak about our trainees, in the way we score our trainees, and in the way we promote ourselves, the way we apply for grants, the way we publish, the way we're paid. There's no difference for this in medicine than any other field. We know that women and men practice differently. We know that they practice medicine differently. We know that women communicate differently with patients. We spend more time with patients. Patients feel more open to ask us questions. Often, the patients will sit down with me and start asking me about the side effects of chemotherapy. And at first, when I started my career, I was really thought this was great because they saw me as a surgical oncologist and that I could answer these questions. But that's not it. It's that the male medical oncologists were not spending the time answering the questions, and they would come to me with their questions. I now see that we're spending a lot of time having this conversation. You should go ask your medical oncologist these questions, because that's really his role, not mine. We know that patients are more apt to ask us questions in Epic inboxes, and so women are spending more time on this paperwork. We know that women are more guideline adherent within their career, and this starts back in early childhood education. We know that women, girls are trained to follow the rules. Boys are trained from kindergarten up to push boundaries and push the rules and see how far they can get without getting into trouble. That's stuff I learned from the kindergarten teachers at the kids' school, not from medicine. We know the quality of care is different for men and women. So how does this impact our outcomes? Just like we would look at the impact of seeing a medical oncologist before having your surgery, or seeing a radiation oncologist before having your prostatectomy, how does this impact outcomes for our patients? So Sugawa et al., it's a group from BI Deaconess at Harvard. They looked at Medicare patients, and this is an internal medicine group, so they were trying to assess how outcomes were impacted, male versus female. They looked at 1.5 million hospitalizations from 2011 to 2014. And then they did a subset analysis of hospitalist admissions, because they figured this is about as close as you can get to random allocation of patient to physician without actually doing an RCT. So based on random allocation of the call schedule, when a patient comes into the emergency department, you're either assigned to hospitalist A or hospitalist B, whether it's Monday night or Tuesday night. That happens to be male versus female. So they did a subset analysis as close to randomizing as we can. And what did they find? So what they found was that outcomes were markedly better for women internal medicine physicians than male. And this got a lot of press, because this is a huge difference in terms of 30-day mortality and in terms of readmission rates. And if it impacts readmission rates, it impacts money. So there was a lot of discussion about this, and this is internal medicine. But the question was, what about surgery? So medicine, there's a lot of thought, there's a lot of communication, there's a lot of hand-holding. Maybe these gender differences are going to be more impactful in medicine. Surgery, very technical, pushing the envelope, thinking outside the box. Maybe men are going to do a little bit better than that, right? Because, technical skills, all those internal implicit biases that we all hold. So Dr. Wallace and Dr. Satkanathan looked at this. These are two urologists at the University of Toronto, and I had the privilege of working with them on this project. And so we set this up within the Ontario health system, so we can see all the cases that occurred over a year. This is a population of about 14 million. And they looked at 10 specialties, 25 procedures, and 1.1 million patients across different procedures. This was matched on the type of surgery. It was matched on other surgeon characteristics like volume and age, because age is going to be very impactful for your outcomes. It was matched on patient characteristics, their gender, their age, and their comorbidities, and it was matched on the hospital where we were practicing. And what was found was that in composite outcome of death and major complication, females had less complications. So if you had a female surgeon, you had fewer complications, lower risk of death, lower risk of readmission, and lower risk of complication. And I'll say that I looked at this and I thought, well, this has got to be wrong. Maybe we screwed this up somewhere. And I was the person on the authorship list going, but did we look at this and did we adjust for that? And are we really sure this is how we want to send this off to the BMJ? But yeah, this is it. So can you replicate this? So Sagawa took the same methodology that we had used in Ontario and applied this again to Medicare, looking at surgical outcomes. And what they found was that there actually is not a difference in outcomes, male versus female, although I would say that this is a trend towards significance because you have a confidence interval of 0.93 to 1.01. So kind of getting close, but across a population of 1.1 million, probably not significant. What they found that was really important though was the how the gender and the age interacted. So the groups that did best, patients who were treated by females did better. Patients who were treated by females in their 50s did the best. So I feel like I'm really entering a great decade here. So this is all good. Yes. And I'll just point out that I'm not sure if I can point out here without sliding my slides too much. Nope, that goes back. Over here on the last bar graph, you can see there are not very many women in their 60s who were in this analysis. So confidence intervals are really quite huge there, and it's hard to know exactly what to do with that part of the data. So the next thing Dr. Wallace looked at was the interaction between the dyad of the patient and the surgeon. So if communication is really critical in this decision making and the getting through the hospitalization safely, is there a difference in the dyad of the patient and the surgeon? And yes, there is. So if you have a discordant dyad, you have worse outcomes for the patient, and especially this last one on the bottom. Among female patients who had a male physician, the hazard or the relative risk of having a complication or having a death is 1.2, which is a very high relative risk. If you have a male patient, whether they're treated by a male physician or a female physician, outcomes are the same. So there's some type of communication issue that's occurring between the male physicians probably and the female patients. Similarly, is there a difference in communication on anesthesia surgical teams? So what happens if you have concordant versus discordant anesthesia and surgical teams? Again, if you have females on the teams, either as a surgeon or as the anesthetist, it seems like the outcomes are better. Same thing here. This is a male-male relationship. At the top is a reference group, and for all the other groups, the outcome is better. So whether it's a male surgeon, female anesthetist, female surgeon, male anesthetist, or female-female, the outcomes are better than the male-male pairing for whatever reason. So the question the group's working on now is why? Why do we find these things? So what we can see is that for patients of female internists and female surgeons, they have better outcomes. There's some interaction between a female patient and a male surgeon that leads to poor outcomes. And there's interactions between male to male anesthetists and surgeons perhaps that are having bad outcomes. And there are many places along this continuum where communication, decision-making, risk-taking is going to impact and where things can break down. So if you start having small bits of communication that are breaking down at each level, you can imagine that at the end of the continuum of care for patients, you may end up with some of these really big changes. So this is part of our group. We have Dr. Jarath is one of our anesthesiologists, Dr. Halle, and then really importantly, and so I put her picture biggest, is Dr. Gottlieb Kahn. She's not a surgeon, she's an anthropologist. So she's a classically trained anthropologist. She's been working with our group for about the past 12 years. And she helps us study why and how, and she's a qualitative researcher and really grounds us in terms of what we're doing because the rest of us are quantitative researchers. So here are the hypotheses. Maybe it's innate technical skills. Maybe it's communication, risk-taking behavior, or are there cultural barriers? There's a lot of research looking at women's perception of their skills and knowledge. And I think if you asked the same question as the SAT question, who's more technically adept, men or women? I think most people would say it's the men. There's actually not really data to support this. There's a lot of data looking at how medical students grade themselves, or how residents grade themselves. And so if you take a group of PGY1s and you ask them to self-assess themselves, and then you ask their staff to assess them, in general, PGY1s underestimate their performance, which is probably a good thing. Residents who have better skills actually underestimate themselves more relative to their skill. And the people who are least accurate at assessing themselves have the least amount of progress over a year. So as you're setting up curricula, this is a really important thing to consider. And Dr. Mentor has a publication from 2004 looking at whether men and women under-assess themselves to the same rate, and not quite significant, but women tended to under-assess themselves more than men did. So which leads me to wonder, are you even good enough to have imposter syndrome? And I think that's one of the problems many of our trainees have. Now, if you look at the way that people, our residents are assessed, this is plastic surgery data. This is 8,000 entrustable activities, so a fair amount of data. It's over 64 residents, 3 programs. 25% of the assessments were by female faculty. The other 75% were by male faculty. The male faculty rated the female residents lower on average than the males, but the female faculty scores were the same for males and females. So some data to let us think that maybe the male faculty is rating women a bit differently. Now, if you take robotic or laparoscopic videos and you send them out for assessment, the male and the female surgeons perform, or the surgical trainees perform exactly the same. This is gynecology work. But I'll point out that there were 17 female residents in this study who did 34 cases and 13 males who did 153 cases. And I thought that was a typo, and so I don't really know how they came to those numbers, but there was no difference in the technical skills, despite their low caseload. This extends to patients as well. And I think this is one of the areas that's really challenging for us to address. So we can address within our centers and within our institutions how we construct our letters of intent, how we do our interviews, how we make our committees. We have a very hard time controlling the general public. If you look at how the general public ranks physicians and what they say about men versus women, they rank women less. This again is going to come back to referrals and how many cases you do, what type of cases you do. And when they talk about women surgeons in their comment section, they comment on comfort and how they talked and professionalism. And for the male surgeons, they talk about how they have good surgical outcomes and how they have good technical skills. I'm not sure how a patient knows your technical skills, but that's what they talk about. So with communication, we know that men and women communicate very differently. So this is probably going to be the driving thing that's we're seeing in all of this. We know that women spend more time with the patients, that they counsel more, and that they're asked more questions. I'm going to talk a little bit about risk-taking. There's a lot of psychology data talking about risk-taking and how men are more likely to take risks. Women are more nurturing. They're less likely to take risks. We talk about skydiving and whether women would do skydiving or not, or would you be more nurturing? What's the relative risk between these two activities? Not that different? So hazard ratio of death is 20 between pregnancy and skydiving. So, so your risk of death is much higher in pregnancy. These are things that we don't think about. So women do take risks. Women take lots of risks every day. Why are we assumed to take less risk though? So there's 2 really interesting articles. One's in Harvard Business Review and one's actually just came out in Forbes. And it talks about how there's this implicit idea that women take less risk, or that we have a bias against risk. Women actually don't have a difference in terms of initial risk taking. What happens is that when men and women take risks, if men take risks, they're rewarded for that. If women take risks, they're not taken down a peg. So there's an inequity of consequences. So women do take risks. We are not risk averse, but our reward system for when women take risks is different than with most men. And this is shown by Heather Sassons, also from Harvard. This is her thesis results. This looks at referral, and Dr. Shapiro talked about this in her presentation. So this follows Medicare patients. This follows referral to male surgeons and female surgeons over time. And what happens here at this line, 4 dots in, is a death in the female practice. So if there's a death of a patient in a female's practice, the referrals to that female from referring surgeon or certain community practice goes down. If there's a death for a male surgeon, their referrals go up. It's assumed that they're taking on harder cases. It was a challenging case. There was a risk that was taken. They went, the extra mile to try to do a difficult case for the patient. Their referrals go up. Female surgeons go down. This extends to your partners. So if I have a bad outcome, her referrals go down. So referrals go down for women across your practice if you have a bad outcome. Same thing is not true for the male surgeons. I think this is a bit of a double-edged sword. I think actually this might be an interesting question that I'll pose the panel and the audience, is risk-taking. And I think while with women, we do have an ability to not take risks. And I would say that in some situations, and we see this play out in tumor board quite often, the men are pushed or egged on a little bit more to take more risks. And I think we have an implicit ability to back down that they don't have. And there's a little bit of ego at play for all of us. One of the worst rules from Cancer Care Ontario was about neoadjuvant chemotherapy for pancreas cancer. So the rule said you can give neoadjuvant chemotherapy if the surgeon says they cannot resect. So we sit there in tumor board. Well, can you resect it? Oh, who backs down from that statement? No one is going to back down. Of course I can resect that. And then we'll say the question should be, should you resect it? But that's not the way it's worded. The word is, can you resect it? Of course I can resect it. And you don't want to get into that situation. I made these slides clearly earlier today because I picked up something from Dr. Shapiro's presidential address, talking about vulnerability and how we should see vulnerability as courage. As hepatobiliary surgeons, we have to do this. We have to do these difficult cases. We have to have that edge and we have to push the envelope. But we also have to have the flip side of it, which is the vulnerability and sitting at tumor board and saying, I don't know if maybe we can, but maybe we shouldn't. Maybe this is not the best thing for the patient. Maybe we should take an alternate route. And so I think that's what we try to incorporate within our tumor boards. It's a journey. We don't always hit the mark on it, but we try. And that's my team, home and at work. And I'll take any questions. Thank you.
Right, do we have any questions from the audience for Dr. Coburn or the panel? That maybe I'll get started. I like the risk-taking approach, and maybe I'll direct this to Dr. Menard. Like, you work in transplant. Do you perceive differences in risk-taking amongst your group, and would that play out in patient outcomes?
I think in our group in particular, it's a real collegial group. And I think, we see transplant as a team. And so we make a decision as a team. And it's really important because oftentimes, even though that team is making the decision, maybe there's only one person there at 2:00 in the morning. And so making sure that you're putting yourself in an environment where, you make that decision together and you live together and you die together is kind of, and being able to go to the patient and say, this isn't just me making that decision. It's the whole team that's saying, you're too high risk or you're high risk, but we're willing to do it knowing that there's that risk I think is incredibly helpful.
So there's more and more models of having like these team practices when in elective HPB surgery. How do you get to that level where you're willing to take the same risk as your your partners that, there was a paper recently from the University of Ottawa where they have a completely shared practice. One of their surgeon will see the patient in clinic, make the decision to operate. Somebody else will proceed with the surgery in the OR. Somebody else will do the post-op. And they all work together and assume the decisions that were made before them. Any thoughts from anyone on the panel on how you get to that level of collegiality and an agreement or in support of each other?
So I worked in a model before this position at Kaiser where it kind of works very much like that. Not so much for as many as the high risk cases, but for a lot of the general surgery cases where someone would see the colon cancer patient, know that they need a right hemicolectomy and sign the patient up. And it's whoever the surgeon, whenever the patient wanted to be scheduled, whoever the surgeon was on that day that felt comfortable doing a right hemicolectomy would do it. And I think it's being able to trust your partners, also being able to have a group of partners that are easily available, especially the partner that has either seen the patient in the very beginning or scheduling it in a way, especially in community practice, where you and your partner are usually operating together. It's not with a resident or it's not with a NP or something like that, but it's usually you and your partner working together. So after a while, when you work together enough, you learn each other's risk level and elevate it together at a time where you can feel comfortable with each other's decisions.
Something you said really like hit home to me is I'm new, like 3 years into my practice, and I really struggle with could I or should I a lot, and especially at tumor boards. Because I think, especially as a woman, having bad outcomes early in your career can really be very damning. And so I guess maybe for the panel or anyone in the audience, like how do you get to a place where you can accept a complication? And I think it's a very like tightrope we walk.
I think that's a really interesting point that you say, for HPB surgery, the most important thing for it a lot of times is just getting back on the horse. We all have complications. Complications happen more often than we sometimes even want them to happen. And being able to get back on the horse when the complication happens is one of the most important things to having a long career. Because oftentimes what happens is when you're not able to take the risk again, is when you end up realizing that I don't really want to do this anymore. I'd rather be doing something else.
I'm talking again, I'm sorry. I just wanted to do a little riff on what Madam President said today when she's talking about the death, your first death in the operating room, and you remember it. And I turned to the guy who happened to be sitting next to me, who was a guy named Shimel Shah. And I told him, he came the year after I did. I told him my first death in the OR as an attending was in my first year with a guy with a right liver, cirrhotic liver, a right lobe resection, and I tore the right hepatic vein. And I called in the chief of vascular and he helped and everything, but the patient didn't have enough reserve, it was a sick patient, and he died. And I just remember that walk to go talk to the patient's wife, and I remember that talk to go and then to call the referring doctor who sent me a patient and say, I'm so sorry. And in talking about pink referrals, Dr. Coburn's talk, and I remember, and I told this guy, I'm so sorry, and we did. I could give him all this explanation. I told the wife, and the wife, although incredibly distraught, was also incredibly understanding. You just feel so humbled by this. And then the referring doctor was kind of a crazy German guy. He said, "Oh, okay, thank you so much for letting me know. Anyway, I have these 3 patients to send you." But the reason why I bring this up about help is that Shimel came the next year. And any of you who know Shimel did not suffer from a lack of confidence as a trainee. He's a very dear friend of mine. But we were set up to kind of be in competition with each other. He's a HPB trained Toronto transplant. I'm a non-transplant, surgical oncology, HPV person, set up at even different campuses. And we were trained at like opposite ends of the universe, the Brigham and the General. And so we were set up to kind of be in competition, but he and I think both made a very systemic decision, or a systematic Machiavellian and probably ultimately very smart decision, that we would be all in together. And so whenever, because we were these young Turks out there in the middle of not nowhere, but without the IR, without the all those things that he was used to in Toronto, and I had been used to I was at MGH and MD Anderson. And so we basically, every difficult case we scrubbed together. I'd go over to university, come over to Memorial, hard Whipple, hard bile duct reconstruction. In our early years, we helped each other, and between us, we really taught the residents a lot. It was not him, it's basically, it was a wonderful experience. So find your, and this is also a he for she thing, but find your allies. And don't judge people ahead of time. Don't think because another one of our very close friends, Caprice Christian Greenberg, and Kim Moore DeLaw, were telling me, all these things I'd heard about him as a resident in terms of being so macho and male. He was like the best partner, and Chris can go tell him this. He was the best partner anybody could have, and he probably helped me with my maybe female, maybe just me, imposter syndrome of the hard technical cases. And I think I helped him with his oncologic thinking. And now he can call himself almost a board carrying surgical oncologist because of my, and an outcomes researcher. So anyway, but I do mean that in all that seriousness, and it's sort of forever partner and someone who can be very helpful to you. So find your allies, find people that you can help them and they can help you.
I think Dr. Minter had a comment, but what I get.
He's right there.
So find allies and don't judge Shimel. All right, Dr. Minter.
So I just wanted to, I was having a really nice conversation with Cecilia, who just had to step out, and Caitlin about this tumor board situation. And I think one of the things, we're all enculturated in a certain way, right? And there are always going to be different philosophies in both medical oncology and in surgical oncology around folks who feel like their perspective is, I'm going to do everything I can to get that tumor out, even if, right? Like, because that's what the patient said they wanted, et cetera, et cetera. And that's their philosophy. And I think, I don't think it is not strictly male, though there's definitely some gender tendencies there that we would observe. But I think for them, it's this sense of like, that's what I can do, right? Like, and I'm going to do everything I can. There are medical oncologists who say like, the chemo's not working, so we should just do surgery. And if you don't do surgery, you're a surgeon who doesn't like to operate, or you're not an aggressive enough surgeon, et cetera. I think, Cecilia was sharing experience and their tumor board, which I think can be expanded upon, where there is a structural way, because again, we're all enculturated in this way of just saying, as you said, in tumor board, just creating an agreement amongst yourselves that we're going to say, for any of these difficult cases, okay, first, is it technically feasible? Everybody weigh in, not just one person, not the vocal person who's like, I can take that out, right? But like, very standard fashion, go around. And then the next question has to be, should we take it out? Or should we do something different? Because I've seen my medical oncology colleagues, interestingly, who are also women in this situation, who their male colleague says, the chemo's not working, so we should operate. And I know them all individually disagree, and they're brilliant, but they don't want to speak up in that setting and sort of be seen as going against what their senior male colleague has said. So if you take a structured approach of just asking everyone in the room, getting everyone's input just as a routine, and then having the conversation about should we, then that opens the door for people to share different opinions. And you will find that suddenly there's a lot of people saying the same thing. It doesn't just have to be you. So I think we're not going to fix all these things we've been enculturated with for hundreds of years and expect people to just be brave and like throw themselves out there, because in some instances that's suicide, but rather just have a structured approach to that. And then the other thing I wanted to share was we found some super interesting data that was statistically significant with entrustable professional activities in the US with our female residents versus our male residents. And it is really around, and I think to be very clear and fair to our male colleagues, they don't overestimate their abilities. They are just much more accurate at self-assessment when you compare to what the faculty, they're just much better at it. whereas women tend to have imposter syndrome and underestimate their abilities. So what we found was the PGY2 and PGY1 and 2 years, the female trainee, the faculty rated them the same. No difference, superimposable curves. But the trainees themselves underestimated their abilities quite significantly when they were female, and the males were very accurate. Interestingly, it came back together at the PGY 3 years. So women gained confidence coming into that PGY 3 year, they were the same. Then they dropped again the PGY 4 years, they transitioned to being new chiefs. PGY 5, they came back together. So it's kind of a perfect demonstration of imposter syndrome, particularly when you're doing something new, you're entering a new environment, you're not quite sure. But I think that tells us a lot about how we all need to mentor and give feedback and really encourage our female trainees to not underestimate their abilities, because then that confidence, that's viewed as lack of confidence, and then that has this whole sort of momentum that's hard to undo.
All right, so we'll go with one last comment with Dr. Orloff, and we'll move on to the next speaker.
I think it's on.
Thank you. Good afternoon. For another great talk. I was struck by your comment with the data on that a woman has a complication and she gets less referrals than a man does or a male does, and they sort of don't suffer from that. And I have an example of a case that, there's a urologic cancer surgeon, and she had a case that she asked me to help her with mobilizing the liver, and the patient had pulmonary Mets, and I was having PEs and pulmonary Mets, not doing well, was obviously, had cable involvement, liver involvement, pulmonary involvement. And I just said, I really don't think it's the right thing to do to take this approach of taking things out with the renal cell, the cable clot, a tumor, because they have pulmonary Mets. And so I said, and this is a quote, maybe it's not the right thing to say, but I said, old doctors let their patients die, young doctors kill them. So she went to one of my junior partners who's a male, and he said, well, I can do this. And he went and helped her, and the patient died the next day. No consequence. I felt like, if I had done that, probably I would have lost my licensure. And maybe that's not true, but I just wonder, how do you circumvent that problem? And how do we, moving forward, make that equality? Because again, it was, in my mind, the wrong thing to do. And instead of listening to me, the surgeon said, well, I'll just go to the next person that's willing to do it, which happened to be a male. And there was no consequence to that. But at the same time, and I have more than 20 years of experience over this person, in terms of, surgical experience. And I felt that there just really wasn't any avenue to address that. And I'm just asking your advice. How do you address that? Because you brought up the data that I wasn't aware of, and I'm just wondering.
Right, very short advice, Dr. Coburn.
Yeah, always. I think it goes back to what Dr. Mentor said, and you have tumor boards and you ask everyone. And I think that also protects you when because you will have bad outcomes. And so if you know there's going to be bad outcomes, you have the tumor boards and you set them up and make sure they're collegial, and it's easier to go to the family and say, we talked about this in a room of 30 people, and that's a lot of what we do in tumor board. This is a terrible situation. They're 30 years old. This is awful. Everybody wants to do something, but we know we shouldn't. And so it's easier to go to the family and say, this is a terrible situation. Everybody at the Cancer Center looked at your films, and everybody agrees that we shouldn't take you to the OR. And make it more about we and the team. And it's easier to tell the patients this is a terrible idea. I think we call it an affair of the heart. When you see the patient and the patient is sitting in front of you and the 2-year-old kid is on their lap, you want to do something. When Paul and Julie see the films and tumor board, they don't have that whole emotional attachment to the patient. And so they look at it and they go, that's a terrible idea. You can see on the films, this is a bad plan, but they don't have the same emotional attachment to the patient.
So remember the structural approach to tumor board. I think that was very excellent advice. So we'll have to move on to our last speaker. So it's a privilege to introduce Dr. Tara Cohen, who is a human factors expert and researcher. She's a director of surgical safety and human factors research in the Department of Surgery, director of simulation research at the Department of Simulation and Interprofessional Education, and a research scientist and associate professor in the Department of Surgery at Cedars-Sinai. Her research interests involve proactive approaches to patient safety through potential threat identification. She also currently serves as a secretary for the Society of Surgical Ergonomics, which is where I had the privilege to work with her and get to know her, and is the co-chair for the International Symposium in Human Factors in Healthcare. She's going to be talking to us about cognitive ergonomics and how that may impact the way that we feel and react in the operating room, which the first time I heard this talk really resonated with me about my experience as a woman in the OR.
Well, thank you so much, Julie, for that super kind introduction. I'm really honored to be here this afternoon, evening, among such esteemed speakers and panelists. So thank you for having me, and hopefully we'll all learn a little bit more together. I certainly learned a lot from the last few talks, so thank you guys for that. I'm a little short, so gotta see. Moving this. Can you guys hear me if I? Okay, great. So I do have a couple of disclosures I do want to share. One is that I am receiving grant assisted surgery study looking at flow disruptions in the OR. And another is my colleagues and I recently published a book focused on human factors, same as ergonomics in surgery. I should have one more disclosure up here, is that I'm not a surgeon, I'm not a physician, I'm a researcher. And so my background is really a little bit different than some of those of the folks that we've heard from tonight. So don't ask me any clinical questions, please. I won't be able to answer them, but we'll kind of get through it together. So as we're in this room, most of us are aware modern surgical care has been really, really phenomenal for improving safety and well-being. We have highly trained practitioners, state-of-the-art technology, and unmatched biomedical research with respect to surgery. However, we continue to see errors, adverse events, harm, and increased costs. And a lot of that is related to surgeon burnout, physical injury, and even results in leaving the field. Now, a lot of this stems from complexity in the operating room. We're seeing the introduction of new complex technologies without any training of how to integrate those technologies, increased richness of the working environment, and heterogeneous teams. So we're seeing reps, techs, nurses, students, physicians, everyone you guys work with on a regular basis, having to learn how to communicate with each other when you're never trained to do so from the beginning. Increase our human error and injury that we're experiencing in the operating room. A lot of this is because there's little attention to a user-centered approach to designing medical systems, and it's forcing our caregivers to really work in hostile, poorly designed environments. So how do we go about reducing error and improving safety and reducing harm in the operating room? Well, a lot of times the approaches we see tend to be reactive in nature. And by that, I mean, we go backwards in time to try to figure out exactly what went wrong after an accident or something harmful happened. We see this a lot in aviation, maritime, mining, those kind of high-risk industries. Nothing's wrong with this approach, right? It does help people in the future. However, it fails because it doesn't help to protect those who have already been harmed, and that includes physicians and patients. So there's a gentleman named Herbert Heinrich who actually studied injuries and accidents in his own factory, and he found that for every one major loss of time injury, so for a crude example, imagine a puddle in a factory and someone slipping on the puddle and cracking their head open, there were 29 minor injuries. So maybe someone seeing that same puddle, slipping on it and twisting their ankle, and 300 no injury accidents. So someone slipping or seeing the puddle, almost stepping onto it, but avoiding it, right? So he argued, why don't we focus less on the sentinel event or the major injury and bring our attention more towards those latent issues that are happening at the bottom of the triangle, those no injury accidents. So essentially what he was describing is focusing on latent factors occurring in the system. This is the Systems Engineering Initiative for Patient Safety, or the SEEPS model. This is something human factors practitioners like myself use daily to understand what's going on in a system and how can we improve safety and efficiency. Of course, we know that technical skill and patient factors will influence performance and success in the operating room, but there are a lot of different factors that actually interact and play a role in that success as well. We know that humans have to interact with other humans with different tools and technologies, performing different tasks in various environments that are governed by different organizations. And those different interactions produce different processes, which in turn end up producing different outcomes, which could be patient survival, provider satisfaction and experience, or even patient experience, right? All of this has to do with cost savings and, of course, longevity and burnout and all of those things that we really care about. So what is human factors and ergonomics, and what does that have to do with this? A lot of you are probably familiar with the term ergonomics, but it actually means the same thing as the term human factors. So if you've heard one or the other, they actually are interchangeable. But human factors or ergonomics is the scientific discipline that's really concerned with the understanding of the interactions among humans and other elements of their system. So that last slide I showed you, human factors practitioners like myself really focus on trying to understand that and improve upon system design. We apply theories, principles, data, and methods to optimize the system and really make sure that we're improving human well-being and overall system performance. And the goals of the science are really to promote safety, influence efficiency, and promote well-being. Now, here, human factors and ergonomics can have different focuses. So one is physical. This is probably what most of you are familiar with when you hear the word ergonomics, right? You're thinking about how high is your desk? Is the keyboard comfortable to type on? Is your chair comfortable? That's really, really very important with respect to women surgeons and how we operate. And I'll touch a little bit on this, but there's also different types of ergonomics, including cognitive ergonomics, which focuses on the brain and how we interpret situations, how we make decisions, how workload influences us in the operating room, and macro ergonomics, which focuses on the design of work systems and their interactions and really aims to optimize the entire workplace. So just wanted to lay the groundwork there before we got too far along. My expertise is in cognitive and macro ergonomics, while we have others who are really quite experienced in physical ergonomics and can tell you exactly what height the table should be at, how far you should be standing, and things like that. Now, how do we study systems and improve them from a very practical approach? What my team and I do is focus on flow disruptions or deviations in the natural progression of a task that might impact the flow and efficiency and safety of that task. So we go into operating rooms and we study these little deviations that in and of themselves may not seem catastrophic, but when they accumulate can be very, very detrimental. They can range from minor inconveniences like a robotic surgeon having to pull her head out of a console to repeat a request because her team couldn't hear her, to very, very serious, like tripping over a wire that's plugging in a heart-lung bypass machine, unplugging the machine and being catastrophic in the operating room. I've seen both in my line of work. And so these things, can very much vary in terms of their severity. What flow disruptions do is they demonstrate a mismatch between the demands of the work, which is surgery, and the resources of the system to support those demands. And they've been shown to increase mental workload, the likelihood of errors, and impact patient outcomes. As I mentioned earlier, they are often latent minor interruptions or failures that can accumulate over time. And what they serve to do is reduce the compensatory resources of the team. So I want you all to kind of imagine you're in this scenario with me that I'm going to describe. Imagine you're on a road trip, right? You're driving a rental car that, you got to an airport, you're going to drive somewhere now to get to your destination. You're in the car, you've got your kids in the back seat, and they're screaming. They're fighting over who's going to play video games first when you get to the hotel or the Airbnb. And as you're driving, you're trying to keep a running list of the groceries you need to get at the store on the way there. So you're thinking, okay, milk, eggs, cheese, what are we making for dinner? Your kids are screaming, and you have the radio on, and you kind of think you hear something about a pileup along your route. So what do? You reach down and you try to turn up the volume so you can hear what's going on. Well, surprise, you didn't turn up the volume. You changed the radio station because you're in a rental car and the buttons aren't where you're used to having them be. So when you do that, you are now flustered. You have no idea what's going on. There's some loud static, and you look down to try to figure out what you did. When doing that, you nearly collide with a pedestrian who's crossing the street while on their cell phone. Now, all of this story, right, is not too difficult to imagine happening. And this is kind of how flow disruptions can concatenate in the operating room and create a window of opportunity for errors and adverse events to occur. And what they do is they increase the risk, or they create a space that we can, really be separated from patients in the operating room physically, but also cognitively. So what my team does is we go into operating rooms, we train them up, we watch a procedure from the time a patient gets wheeled in all the way until they're done and they get wheeled out into the PACU or recovery area. And we're trying to understand, what are these little deviations or disruptions that disrupt your flow? What makes it hard for you to do your job? Not because of anything related to skill, but because of the system not being efficient or designed appropriately to support you. We tend to see a lot of things related to communication, coordination, so how your team works and supports you, equipment issues, breaking or not functioning appropriately, a lot of interruptions. So these could be alerts, distractions, people coming into the room and interrupting your flow while you're in the middle of a procedure, the layout of the room impacting the performance, and the usability of products and design. And as I was explaining before, oftentimes these flow disruptions can accumulate and create what we call an error space. And what we did is we studied this actually in cardiac surgery. And what we saw is that every time the surgeon had to interact with one of these disruptions, whether it was the team not understanding a request, the team having to communicate specifically, waiting on tools or technology, we looked at the time that it took to interact with those disruptions, and we saw this kind of error space create itself. There were this big window of opportunity where at least partial, a part of the compensatory resources of the surgical team were spent allocating to these disruptions. And so we saw over 24 cardiac procedures, almost 700 flow disruptions, and they related heavily to interruptions, communication, and coordination. And why is this important? Well, it helps us pinpoint the areas in the system that we might be able to fix or mitigate by introducing systems level redesigns. So what does this have to do with stress and how we make decisions in the operating room? This is the surgical stress effects model, and it's a lot. We won't spend all day going over it. I'll go over it quickly. But essentially, we can kind of see how these flow disruptions can fit into this model and cause stress and relate to harm and safety events down the line. So essentially, these flow disruptions, again, they really serve as these mismatches that exist between the demands of the work system and the resources available in the work system. So we'll get to the flow disruptions, but what I want to do is talk about how all these little inputs into the surgical stress effects model can really play a role in how you're performing throughout the day and how you feel while you're conducting surgery. So from an individual provider and team factor standpoint, we tend to see that lack of experience, for example, can relate to interruption and coordination type disruptions. But from a team's perspective, if you have lack of trust in the operating room or you're failing to share or speak up because of biases that exist, it can lead to miscommunications. From a patient factors perspective, patient complexity might require other things we didn't originally think about, right? Like additional equipment, staff, or resources, leading to coordination or equipment challenges down the line. From the organizational structure factor, things like hierarchical culture, lack of speaking up, fear of retribution can all lead to threats and errors. Also, poor resource management can lead to limited availability of equipment and specialized staff, which will relate to errors and challenges down the line. We see a lot of issues related to the environment and technological factors associated with surgery. So oftentimes tools are not designed for the female surgeon in mind. We'll talk about this a little bit more, which will relate to use errors or stress or physical pain and injury. We can also see that noise or distractions can decrease our ability to communicate with one another and impact technical performance. All of these things will elicit different stressor responses. They can be emotional, physiological, and behavioral, and they will then impact our ability to perform. Individually, stress is associated with lower psychomotor performance, and it diminishes your working memory, attention, and creates issues in your judgment and decision-making. From the team perspective, stress is actually very contagious. So if one person is stressed, that can actually get all the other people in the room stressed as well. And stressed team members are less able to coordinate and cooperate with one another, reducing performance. Of course, this will impact efficiency as well as outcomes. So harm not only to the patient, but injury and harm to ourselves as well. So what I'd like to do is talk about one example and kind of walk through this from a perfect storm situation. So I want everyone to imagine a young female surgeon who's going in to perform a very complicated case, maybe one of the first times. So she's done a lot of work and research preparing, and she's ready to go. And ahead of time, she requests a very specific clamp, right? Because this is what she wants to use, and she feels very comfortable using this. Well, at the critical stage of the procedure, this clamp is not available. The scrub tech hands her a much heavier clamp. And now she's nervous. She's getting a little uncomfortable. Her heart rate is increasing. Her face is flushing, right? She's didn't expect this to happen. She's starting to feel like her job demands are outweighing the resources available to her. So she nervously slams the instrument down and she, kind of startles the team in the room because she's frustrated and scared and doesn't know what to do. And you start to see her team is now has a heightened awareness, and they're a little bit nervous and not wanting her to feel stressed or uncomfortable. Now, her hands start to shake. She's feeling that I have to go ahead and perform regardless. This clamp is heavy. It's causing pain. She's feeling pain in her arms and her neck. And, as she's trying to focus on her patient, she stops communicating with her team because she's nervous. She doesn't, feel that she has the extra compensatory resources to have conversations and be sharing information as she normally would. The team then doesn't feel like they can communicate and speak up with her, starting to create this storm of issues. Because she's so focused, she fails to notice some blood loss that's happening in the room. Similarly, the nurse who's in the room has a heightened awareness, doesn't want to get in trouble or doesn't want to get yelled at or further frustrate or make the surgeon more anxious. So she's distracted. She fails to notice the blood loss. And then when she does, she doesn't want to speak up and interrupt the surgeon or the team, right? So in the moment when the surgeon needs her team the most, she feels like she's falling without a parachute because of what's happening due to disruptions in the operating room that may have been better controlled if we had a systemic understanding of what was going on. If we looked at everything from the perspective of the system, when we took a look at how we communicate, the tools and technology available to us, the hierarchical organization of the room, we might be able to prevent some of these things from occurring. So when it comes to ergonomics in the female surgeon, we've heard some wonderful talks today kind of talking about how there are differences between male and female surgeons. Specifically here, we're physically different, right? Younger, shorter, tend to have smaller glove sizes, and we have different stressors in our lives. We have different experiences with family and work life, and as described earlier, we face different challenges with respect to discrimination, pay gaps, and promotion inequality. All of this will result not only in more discomfort and pain, but also more cognitive fatigue. And that, as you saw, can kind of, further create an issue with respect to the perfect storm. Now, all of this will require the redesign of instruments, the redesign of the workplace, and ultimately the redesign of the system. So if we really want to improve surgical experience for female surgeons, we have to consider ergonomics. We have to consider all three types of ergonomics as well. From a physical perspective, we should be redesigning tools and technology and the environment to support, especially female surgeons in the operating room, but all users in the environment. From a cognitive perspective, we need to think about how do we communicate with each other? How should we be trained to communicate with each other to promote teamwork, reduce fatigue, and improve workload? And from a macroergonomics perspective, how can we redesign policies and procedures and practice and change the process so that we're protecting the people in the system? Now, all of this will require immense collaboration. It's going to require collaboration with surgeons who are actually in the room, with hospital leadership, but as well as industry, the folks who are designing the tools and technologies that we're using every day. And these potential interventions should really be explored based on how they impact different work system factors and interactions. So with that, I will end there.
Thank you very much, Dr. Cohen. I think that this had the first time I heard it really resonated with me, as we're often told in DOR that those are inconveniences, that you don't have the right instrument, that you're a princess because you asked for the instrument 3 times, because you want the monitor to be positioned differently because you're shorter than your male partner who was there the day before. And the answer I got is, you just got to be more resilient, like let it go, do your job. And now that there's data and there's science that can explain how this is disruptive and can actually impact our patients, Now, maybe I wanted to hear from Dr. Facundo. You work in a different system than we have in the US or in Canada. How does this work out for you in Colombia?
Well, thank you. I'm actually a gastrointestinal surgeon, and my team is half and half, women and men. But I would like to comment briefly. When I finished my training like a general surgeon in Colombia many years ago, only 10% of surgeons in Colombia were female. Now, I'm not sure about data, but maybe 25%. I know it's not a lot, and I know that numbers are just a little part of the panorama, but I really feel things are changing. The field traditionally dominated by men have been changing in favor of women, and this wonderful session supports my feeling. So thank you.
I just wanted to make another comment. You know, I loved all your graphics, Tara. They're really great. But, you know, you described certain scenarios where it's the minor disruptions that kind of happen in the operating room, the wrong clamp, the wrong stitch. These days, there's so many travelers. I oftentimes walk into the operating room. The only person I recognize is the anesthesiologist because you don't have the same team that you normally have. These minor disruptions, what oftentimes that cause stress in you when you are operating and trying to do your best, oftentimes lead those people to interpret your stress as you being the disruptive surgeon. And these days, there's such a problem with write-ups and easily being able to do write-ups on anyone, whether it's because of the tone of voice or the inflection in your voice or changes, that the write-ups become such a big problem that for a lot of HR things, they don't even look at the write-ups. They just look at the volume of the write-ups, which leads for a lot of people into having difficulties in renewal of contracts and being considered a disruptive surgeon when you really are not. And it's more the actual facilities that's actually available. So and that's a problem more, I think, a lot of times for women surgeons than it is for others.
And it's interesting how bias influences the system, right?
Right.
And the system you work with is not the same depending where the bias is located. Just had a comment. Oh, there, the microphone is coming to you.
I was just going to add to Purvi's comments right there. It is very true. That perfect storm, my male partners would have been screaming. Everyone's running. I mean, my chairman does this too. Everyone's running around to get the thing. And I have these issues and I just say calmly, can we get this? But I do have very good communication skills with my OR. It doesn't matter if they're new people or not. It doesn't matter if they're on my team or not. Everyone says, I love going to Dr. Galka's OR because I'm always calm. I never raise my voice and I just ask for what I don't want a lot of things. So I keep it very simple. But when you have that perfect storm, how do you? Like sometimes I just want to scream and I hold it all in and I remain calm. Okay, I won't use that. Or okay, I'll find something else. But how do you not look like the disruption when it's really the system?
I think that is a really hard thing. And in this day and age, it seems to be getting worse because of how much is available anymore, whether it's from available support staff that know you to just other things that are just available in the operating room itself. And with the staffing issues and everything else that's going on, it's becoming more and more of a problem. And you're right, what a woman says, or it might not even be what she says, it might just be the tone in what she says is compared so different than what a male surgeon would say it in.
So maybe I'll leave the last word to Dr. Cohen by asking, like, ideally, we want to prevent these things, want to build systems that are resilient rather than putting the resilience only on the individual and have systems that prevent those slow disruptions. But when the perfect storm is lining up, are there systematic ways that we can break it?
Yeah, that's a great question. So I think a lot of that has to do with thinking about each factor in the system. So how can we promote resilience for each of those factors that are interacting? So that might mean putting everybody through stress training, right? How do you focus and learn how to communicate when you're under stress? Because unless we're practicing that in a simulated environment that's highly that has very high fidelity, we're not going to be able to perform effectively. One way to answer that too is, pilots, what they do is they go through and they practice and practice and practice incidents. And they'll do it in the operating room. They'll do it in the aircraft over and over again. We used to go through spin training. We would make pilots go through and do spins over and over and over again so that they could recover. So I think a lot of this is learning how to practice and behave for yourself, understanding what are the warning signs that I am feeling that perfect storm coming on, and how do I ask for help? And how can my team understand when that perfect storm is coming on and support me? We don't really do a lot of training as an entire team together. Surgeons are typically trained as residents in simulation centers or in classrooms alone. Nurses are trained separately, techs are trained separately, but we don't come together as a team in a high fidelity, high stress environment to learn how to support one another, especially when stress starts to occur. And I think hopefully technology will start to help us with that. We'll start to be able to identify when folks are feeling stressed and anxious and how the team can be aware of that and support one another.
That's great. Thank you. That's a great conclusion to this session. So with this, I think we'll conclude. Apologies for running late. We started a bit late as well. But I think the banquet is tonight, so we'll see everyone there.
A really good session. Thank you so much. I really loved all your graphics. Excellent graphics. That were so cute. And yours